You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 20th, 2019. This week, a risk score for device infections, conflict of interest, fragility index, rhythm control of AFib, and some year-end comments. Let's start with something called the PADIT score, P-A-D-I-T. Infection of a cardiac device is a serious problem, especially after generator changes, because after a gen change, you have to remove chronically indwelling leads, and this requires extraction, which is a big deal. Now, everyone understands the basic ways to prevent infection. Sterile techniques, preoperative antibiotics, good closure, avoiding hematoma, etc. But an under-recognized tool in prevention of device infection is the decision to do or not do the procedure in the first place. And here is where a novel risk score that's designed by Canadian investigators led by Drs. David Burney and Andrew Kahn may help. They call the risk score the PADIT score, which is named after the PADIT trial published in 2018. The trial was a large 19,000 patient multi-center cluster randomized controlled trial done in Canada, where they tested two strategies of infection prevention. One was the conventional pre-op cefazolin. The other arm was incremental treatment with pre-op cefazolin plus vancomycin plus antibiotic pocket wash plus 2 days of oral cephalexin. The rate of hospitalization for device infections in the conventional arm was 1.03 and 0.78 in the incremental arm, and the 23% relative risk reduction did not meet statistical significance. And again, this was published in 2018. This month, the authors, again publishing in JACC, have used data from the PADIT trial to develop the PADIT score to predict infection. Now, this score ranges from 0 to 15. There were 5 independent risk factors that were found in regression analysis, and these were the letters of the PADIT score. P stands for prior procedures, A, age, D, depressed GFR, I, immune compromised, and T, the type of procedure. Now, as the PADIT integer score increases, the infection risk goes up. And in the PADIT trial, the average infection rate was only 1%, but when the PADIT score reaches greater than 8, the device infection rate is approximately 4%. For instance, a 69-year-old man with renal dysfunction who has reached ERI of his second primary prevention ICD has a PADIT score of 8 and therefore a device infection risk of 3.5% with conventional antibiotics. Now, the authors have created a web calculator called padit-calculator.ca. Now, there's caveats, of course. The risk score should be externally validated in another population, and Bernie and Cron wrote to me that they are working on that now in another trial population. Of course, the C statistic, an estimate of discriminating patients with and without future infection, was only 0.7. Coin toss is 0.5. The CHA2DS2-VASc score is about the same at 0.7. I like this score because if you have a frail patient coming up for gen change, let's say he or she is not dependent, there's chronic kidney disease, maybe the patient's on steroids, and it's the third change of an ICD, you can pull up the PADIT score on your computer, you can show it to the patient, and then both parties can have an objective or somewhat objective measurement of the significantly higher risk of complications. This is good knowledge because it informs the decision to perhaps not replace the device in the first place. Second topic is conflicts in the guidelines. Now, you would think that the relationship with industry disclosure of doctors who write guidelines would be accurate. The writing committees that I've participated on have taken industry conflicts quite seriously. But not really. A recent study from a group led by researchers at George Washington University found a concerning level of discrepancy between guideline author disclosure statements and industry-reported payments. Well, Circulation Outcomes published a study looking at disclosed relationships in 9 ACC and AHA guideline documents, and it compared it against what is reported in the Open Payments Database. Now recall that CMS established the Open Payments Database as a component of the Affordable Care Act, and Open Payments requires commercial entities like industry to report physician and teaching hospital payments to CMS. The Circ Outcome study involved 81 guideline authors and nearly 1,000 author-company combinations. The key finding was this: of the nearly 700 relationships disclosed by either source, the author or the open data, only 9% were reported by both parties. Steve Nissen from the Cleveland Clinic wrote the editorial, and he said, despite good intentions, the oversight of conflicts of interest within guideline committees by the ACC and AHA are not entirely effective. But he was pretty fair in his editorial, and he noted that the open payments are not always accurate, as well as the fact that it takes a lot of time to correct inaccuracies in the record. The findings of this paper are provocative, but the authors do offer a balanced take in the discussion section. For instance, underreporting of conflicts is not the only reason for these discrepancies. I mean, it might be a lack of congruent reporting methods. It might be varying guideline duration. Some of these guideline documents take forever, and that may fall outside the disclosure window. And, rectifying inaccurate information is a multi-step process, and the onus is on the physician. But in the next paragraphs of their paper, they really nail it. They say that even smaller dollar amounts can have an effect, and they cite a study showing that even gifts under $20 associate with increased prescribing of the drug. And I would say, of course, these gifts and relationships have an effect. Otherwise, industry wouldn't offer gifts. So this study makes the podcast for two reasons. One is that guidelines have so much influence, they absolutely positively must be made as free from conflicts as possible. And the second thing is that while dualities of interest need not be considered nefarious, they must always be considered. Third topic is Fragility Index. And the first thing to say about the use of the Fragility Index to judge the robustness of cardiovascular research is that I was an author on one of the two papers that I'm going to discuss, so I'm conflicted as heck here. But that said, we should talk about the Fragility Index. The FI is the minimum number of additional events needed in one of the arms of a trial for the p-value to cross its significant threshold and flip the trial to a non-statistically significant result. If the Fragility Index is low, it indicates that statistical significance would be lost with a very small change in outcome events. Now, the first paper, I think, on the Fragility Index comes from the McMaster's group in Canada, and it was published in the Journal of Clinical Epidemiology in 2014. The first author is Michael Walsh. They offer a helpful hypothetical example in this paper. Consider two RCTs to evaluate a drug compared with placebo for the prevention of MI. Both of these trials have a p-value of 0.02. In the first trial, 100 patients are randomized to get drug A, 100 patients to placebo. Fewer patients who get drug A suffer an MI, 1 versus 9 patients, p-value 0.02. The second trial randomizes not 100 patients, but 4,000 patients to receive drug B and 4,000 patients to receive placebo. Fewer patients who receive drug B suffer an MI, 200 versus 250 patients. Again, the p-value is 0.02. In the first trial, if only one more patient had an MI in the treatment arm, the p-value would change to 0.06. But in contrast, in the second trial, the one with thousands of patients, adding one event to the treatment group would have no impact on the p-value. Now to the two papers on Fragility Index published in Circ Outcomes. Dr. Shahzeb Khan from the John Stroger Hospital of Cook County, Chicago, led the first study. This was the one I was a co-author on. We looked at 123 cardiovascular RCTs that were taken from 6 high-impact journals from 2007 to 2016 and found that the median FI Fragility Index was 13. But In 28 trials, which was about 23%, the fragility index ranged from as low as 1 to 4. And in 37 trials, which was 30% of cardiovascular RCTs, the number of patients lost to follow-up was greater than the fragility index. Surgeon Mario Godino from Cornell, New York, led the second study, which looked at the fragility of RCTs underpinning the current guidelines on myocardial revascularization. And they, too, were concerned with the fragility index relative to the loss to follow-up. And they found that more than a quarter of RCTs that support myocardial revascularization have a fragility index of 3 or lower, and almost half, over 40% of trials reveal a fragility index that is lower than the number of patients lost to follow-up. So, taken together, these two papers find that much of cardiovascular evidence is less than robust. But let's be clear, just because a small number of events could turn a p-value from 0.04 to 0.06 does not mean that a trial is, quote, negative or shows no effect. We should reject the notion of having binary cutoffs of saying yes, a treatment works or no, it doesn't, depending on the p-value at 0.05. And it's also important to point out that many smart people think that the fragility index is less than useful. The accompanying editorial from Henry Seligman and Daryl Francis and colleagues pointed out the challenges of fragility index. Many on Twitter reiterated these critiques. Number one, the fragility index says nothing about other important questions of a trial, such as the biases of the study design, the quality of the blinding, and crucially, the external validity of the data. And of course, to this criticism, I say yes, there is much more to appraising a trial than just the statistical interpretation. The editorials also question how much the fragility index adds to the p-value itself. I mean, the FI can only be used for dichotomized outcomes. What I mean by that is alive or dead, MI or no MI. The fragility index does not apply also to time to event outcomes, which are common in cardiovascular trials. And again, I agree. Another critique of the fragility index is that it's simply repackaging of the p-value. Namely, the larger fragility index values can be achieved for a given effect size simply by allowing for a larger sample size. And of course, that points to the ethical challenges and cost of adding more patients to a trial than is needed. To these criticisms, I also agree that fragility index is in large part another way to approach p-values. But the thing is, for better or worse, the p-value remains a common way that medical evidence is adjudicated today, and it's hardly controversial to say that many regular doctors, like me, struggle with p-values. So the fragility index attempts to make a quick and dirty estimate of the robustness of the p-value. Now, the editorials emphasize the confidence interval. This, they write, contains all of the information that is contained in the p-value and fragility index. And again, I agree. And in my efforts to translate medical evidence in writing and on this podcast, I have and will continue to report not just the point estimates, but also the upper and lower bounds of the confidence interval. In summary, I think Dr. Raj Mehta captured my thoughts on the fragility index quite well. He wrote on Twitter, "Many guidelines present study interpretations with little consideration of error due to chance. Biomedicine," he said, "is not like physics and chemistry where we have replicated studies hundreds of times. Therefore, some reminders of epistemic limits and humility are helpful." Fourth topic today is rhythm control and atrial fib. And before I discuss an observational study from respected researchers that was published in the Journal of the American Heart Association, let me first say that I think one of the biggest errors made in AFib care today is overuse of rhythm control. Rhythm control of AFib has a role, but it has substantial risks and requires careful doctoring. I see patients treated with rhythm control who have near zero chance of ever maintaining sinus rhythm. The study in particular used the Get With the Guidelines Heart Failure Registry, which was then linked to Medicare claims over 2008 to 2014, and this was used to describe the current treatments for rate versus rhythm control and subsequent outcomes in patients with heart failure and preserved ejection fraction and AFib. Now, the randomized groups were about 1,900 patients who had rhythm control. This was drugs, ablation, or cardioversion, against nearly 14,000 who were treated with rate control. And the authors found that there was a higher higher all-cause death at 1 year in the rate control arm compared with the rhythm control group, 37.5 versus 31 respectively, and this difference remained statistically significant after adjustments. This study makes the podcast primarily so that I can push back against its findings that rhythm control in older patients with HFpEF may have lower 1-year all-cause mortality. I also highlight it because it is a perfect example of how observational studies can mislead us. Actually, though, the authors do a great job of this in their limitations paragraph in the paper. This paper tempts you to think that rhythm control might be helpful, and I would say don't be misled. And I'll here just use the author's very clear words about the biggest problem with the analysis. They write, there is a potential for bias related to unknown and unmeasured underlying health status in each group of our patients. Although we adjusted for clinically relevant covariates in patients with HFpEF and AFib, other measured and unmeasured variables may have influenced these results. This was perfect. In other words, the choice to do rhythm control was made by a clinician who saw that patient, and many factors went into that decision, and only some of those factors are captured in a registry database. I am nearly certain that the reason rhythm control patients outperformed in this study was that healthier patients were chosen for rhythm control. This selection bias is exactly the same reason that observational studies have shown that, say, surgical left atrial appendage closure looks better than not closing it, or conversely, that digoxin use looks worse than non-digoxin use. Healthier patients got their appendage closed and sicker patients got digoxin. So the only way to answer the questions like rhythm control versus rate control is to take away the clinician choice and make it random. Then you can attempt to understand causation. When in doubt, randomize. This criticism is certainly no knock on the authors. They added the sentence on the need for RCTs in the conclusion, and they did an amazing job of listing the many limitations of their study in their discussion. I would just summarize and say, my friends, please be careful with rhythm control and interpretation of observational analyses. Some end of the year comments. First is up on the heart.org Medscape Cardiology site now is Stanford's Bob Harrington and Harvard's Michael Gibson's recap of the top trials of 2019. This is worth a listen. My top 10 list is also published and is more of a top stories of cardiology this year. I even give a medical conservative award to a group of researchers. A few people who deserve a shout out. My editor, Tricia Ward, is an incredible pro. She keeps my writing honest, fair, and accurate. I had no idea how big a role an editor played when I first started this. And what's more, you should know that Tricia's leadership of the features section of this site should give you confidence in its content and fairness. The news team also deserves mention. Susan Jeffrey, Patrice Wendling, Steve Stiles, Sue Hughes, many others are an impressive group. You all should know how hard this group strives to bring you a nuanced and fair take of the big news in cardiology, and I'm honored to have learned from them over the years. Finally, I want to thank the leadership of the heart.org Medscape Cardiology for their support of my sometimes contrarian view. Thanks to Joanne Stranges, Ivan Oransky, and of course, Eric Topol. I wish you all a happy holidays. This week in cardiology will take Christmas week off, and I'll return January 3rd. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend. Consider giving us a review and a rating. That way other people can find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.